My name is Dr. Nadia Amin. I'm one of the endocrine consultants in Leeds. So I was asked to talk about the endocrine aspects of DiGeorge syndrome. So I was allocated half an hour, but I don't think there's half an hour's worth of chat. So hopefully you'll get us back on time, I think. So I'm going to talk about some of the different endocrine aspects of DiGeorge syndrome. So the main thing that people know about is parathyroid function, and we'll talk about that in most detail. And then we'll briefly touch upon thyroid function and short stature. So parathyroid glands are derivatives of the third and fourth pharyngeal pouches, and we know that microdeletions in DiGeorge syndrome result in failure of development of these pouches with anomalous migration of cells derived from the cephalic neural crest. And then this results in parathyroid aplasia or hypoplasia. So this is just a diagram to illustrate that. So you can see where the what the pouches go on to develop in terms of the parathyroid gland, and it explains why there are issues with parathyroid gland development in DiGeorge syndrome. So just as a reminder, so parathyroid hormone acts to maintain calcium levels in the serum, or in the plasma. So it acts on the bone, and it acts on 1-alpha hydroxylase, which hydroxylates 25 vitamin D to 125 vitamin D. So if the parathyroid glands detect that the serum calcium level is low, you get increased parathyroid hormone release, and you get increased calcium release from the bones, and also increased action of 1-alpha hydroxylase. So you get increased calcium absorption from the gut and from bones as well. So both of these will result in a normalization of serum calcium levels. So we know that calcium in utero goes from the mother to the fetus. And so we can see that in pregnancy, the majority of maternal calcium intake goes to the fetus, and that's also the case in lactation. In DiGeorge syndrome, because you can get this aplasia or hypoplasia with the parathyroid glands, the active transport of calcium, when that's interrupted at birth, there'll be a period of time where there's insufficient calcium intake, and so increased demand on the parathyroid hormone. Because there's this reduced parathyroid hormone reserve, there's a resultant hypocalcemia in the infant. So this is just what we would expect in an unaffected newborn. So you can see that there'll be a physiological drop in calcium in the first day or two of life, with a resultant increase in parathyroid hormone level, and then increase in the 125 vitamin D, which will be partly due to that increased PTH. And so if you don't get that increase in PTH, you'll get hypocalcemia, and that's why the hypocalcemia is most common in the neonatal period. Many infants will be asymptomatic, but symptoms typically develop at around when the calcium drops to below 2 millimoles per litre. Obviously, some of these symptoms will not be detectable in the neonate. These are symptoms more in the adult, but you might notice them to be jittery, have seizures, or muscle cramps, and they can get cardiac arrhythmias due to the hypocalcemia with prolonged QTc or conductive abnormalities. Although it's most common in the neonatal period, there have been case reports of it presenting in adolescence or in adulthood, and this is typically at times of stress. So this is the typical case will be an infant around 5 days of age. They'll have, they may present with a seizure, and they'll be found to be hypocalcemic, high phosphate, and you can see that the PTH, although normal, is abnormally low for the calcium level. So you'd expect the parathyroid hormone level to have increased proportionate to that hypocalcemia. So they were initially treated with IV calcium and then changed to oral calcium and alpha calcidol. And by 4 years of age, they're on alpha calcidol alone and have well-managed calcium levels. So when we try to look at how prevalent hypocalcemia was, it's quite difficult because of, a lot of patients may be undiagnosed. They'll have varying degrees of hyperparathyroidism, but the reports seem to be around 50 to 70%. About 36% of patients with DiGeorge syndrome will have hypocalcemia in their neonatal period. And the natural history is not particularly well characterised. Some neonates, the hypocalcemia will be transient, and so as the dietary calcium increases, the remaining parathyroid hormone levels is sufficient to meet metabolic demands. But then you may get clinical hyperparathyroidism precipitated at periods of increased metabolic demand. So that may be during prolonged surgery, pregnancy, illnesses, or adolescence. There have been case reports of 57-year-old men who've gone on to be found diagnosed with DiGeorge syndrome as postoperatively they were hypocalcemic. And for some patients, hyperparathyroidism is permanent. So obviously, if you've got parathyroid aplasia, you'll have permanent hyperparathyroidism. So just a brief reminder of your differential diagnosis. So if you have an infant who is hypocalcemic and they will have, the PTH is really an excellent differentiator. So if you've got a low or relatively low PTH, you'll need to be thinking about whether it's an isolated congenital hyperparathyroidism, so that can be sporadic or familial, or calcium sensing receptor mutations. So it's useful to do parental blood tests, so looking at their calcium, vitamin D, and bone profile, and PTH, sorry. You can get acquired or secondary hyperparathyroidism. So this is less likely in the neonatal period, but you can have maternal hyperparathyroidism resulting in the infant being hyperparathyroid, and I've certainly seen that quite recently. The autoimmune conditions tend to be in later life, and again with thalassemia or Wilson's would tend to be later than the neonatal period. And of course, it's always important to check the magnesium, because magnesium is required for parathyroid hormone secretion during hypocalcemia. So if there's a defective either absorption or excretion of magnesium, you can get a hyperparathyroidism, and so you may go on a bit of a wild goose chase unless you correct that magnesium level. The most common cause of hypocalcemia are patients with high parathyroid hormone levels, and they'll be commonly the vitamin D deficiencies or the impaired vitamin D metabolism, or pseudo hyperparathyroidism. So treatment is relatively, it's not always straightforward, but in principle it's straightforward with IV calcium if the calcium level is very low, and maintenance is with alpha-calcidol and IV and oral calcium. But actually, in reality, a lot of these patients do have very significant fluctuations in their calcium levels and may need prolonged periods of time for IV calcium. So good access is crucial. So it's also recommended that in patients who, even if their hyperparathyroidism has resolved, if they've had a history of having hyperparathyroidism, pre and post-operative calcium monitoring is appropriate. So the higher risk patients are those with previous hypocalcemia, or if they're going to have a longer or more invasive procedure, or procedures that will result in prolonged periods of time nail by mouth. So when managing patients, we aim to maintain the calcium in the low normal range because there's high urinary loss of calcium, so there's increased risk of nephrocalcinosis. So going on to some of the other endocrine issues in these patients. So short stature is relatively common in young people with DiGeorge syndrome, and there have been specific growth charts developed for this population. It's noted that they tend to have poor growth mainly in childhood, but then the final height is most commonly normal. But a small percentage of patients may have growth hormone deficiency. So in the very short, patients with DiGeorge syndrome, so if their height at STS is less than -2.5, or if their growth is significantly less than their midparental height range, it may be appropriate to go on to do growth hormone stimulation testing. So this is the 22q11 specific growth chart. So you can see, so the pink lines are for those patients with DiGeorge syndrome, and the grey lines at the back are the normative data for the population. So you can see that they do tend to start off significantly shorter, and that continues throughout childhood, but then catches up in later teenage years. So going on to the thyroid gland. So you can also get congenital anomalies of the thyroid gland, as the thyroid gland originates in part from the neural crest cells of the fourth and fifth pharyngeal pouches. So as we know that a DiGeorge is a developmental defect of the third and fourth, you would expect some developmental abnormalities in the thyroid lobes, and autopsy reports have revealed multiple abnormalities of the isthmus or the thyroid lobes. But variable rates of hypothyroidism are reported. So primary hypothyroidism is only reported in around 0.8% of patients. It's not particularly common, but autoimmune hypothyroidism is more common and can occur in up to 30% of adults. There have been case reports of hyperthyroidism as well, but that's much less common. So when you're evaluating an infant with DiGeorge syndrome, we'd, of course, they'll need monitoring for their calcium levels, particularly in infancy and during periods of stress. If patients are normocalcemic and so aren't under the care of an endocrine team, it's important that they are counselled about the symptoms of hypocalcemia. So things like paresthesias, muscle cramps, tremors, rigidity, or new onset of seizures. So they can seek help or blood tests if any of those symptoms occur. We recommend baseline thyroid function tests. The congenital, the Guthrie test will pick up the primary hypothyroidism, but as they get older, periodic thyroid function testing would be appropriate. So in summary, DiGeorge syndrome should be considered in any neonate with hypocalcemia and hypoparathyroidism, even if that's a relative hypoparathyroidism. So always check a PTH along with bone profile and vitamin D when hypocalcemic. Of course, if they are vitamin D deficient as well, it slightly muddies the waters, and so that always needs to be corrected as the calcium is corrected as well. In DiGeorge syndrome, hypocalcemia can present late, particularly during periods of stress, and the diagnosis can be delayed due to the variability and severity of the clinical manifestations. These are just some of the references. There's a couple of different articles, and there's the growth chart is available online as well. So it's short and sweet. Any questions?
Thanks, Nadia. That was good. Any questions from anybody? Oh, we've got a hand up. Jane Marshall.
Hi, Nadia. Can you hear me all right?
Yeah.
Yeah, great. That was really helpful. Thank you, because this question has come up a fair bit for me. You said it can present later, hyperthyroidism. How much later? Because I have a child who it wasn't found in infancy, and he's now school age. I've known him through, 7, 8, 9. Obviously, I monitor it. What proportion of children would present that late? Is it very, very low?
Yeah, I think it's very, very low, because it is literally isolated case reports tend to be pick it up rather than it being. There's no data to say the numbers are representing later. I think the rest, when I marshal the views of the rest of the team, actually they tend to, if they're normal calcemic, they're often discharged, but with advice about symptoms of hypocalcemia. So testing if symptomatic, or if they're going for any procedures rather than routine testing, because I think, there was a case presentation of someone who was 57. So, it seems a bit extreme to be continuously testing these individuals. But I think periodic testing, if they're having other bloods, is sensible. Or if they're
I was just referring to that, the very helpful guideline that we were told about earlier today through Max Appeal, that recommends, monitoring within certain age groups, although not necessarily annually. But I admit I have possibly done it once a year or once every 2 years still, because this young man has lots of other difficulties and surgeries that would cause physiological stress. And there have been occasional sort of anomalies. So it's just been worth following up. And hence I just haven't been able to find out how likely it would be. So that's helpful. Thank you.
We tend to measure ionized in the neonates, Nadia. Is that acceptable rather than serum? I presume it's going to be low for both, or?
Absolutely, with the same, it's fine.
Yeah. And Lorna's got a question.
Hi, Nadia. It's Lorna Hyatt here from Hull. I wanted to just ask about the growth charts. And because I know one of our patients in Hull is on treatment for growth hormone deficiency. And I just looked back at the Max Appeal information about growth. And I have to say I wasn't aware that there were specific growth charts. And I wondered if, are they readily available? And presumably they would highlight if the growth is deviating off normal, so that we're not missing patients that we should be screening and referring on to endocrinology.
Yeah, I mean, this is relatively, I'm happy for my slides to be shared, and then the references at the back, which has the growth chart on it. I mean, I'll be honest, I'm not sure how many people use them all the time, but they are there, so they can be used. And then, yeah, as you said, it is useful to know if they're growth hormone deficient. I suppose they're in that slightly different cohort, aren't they? And I think in the study where I looked at 95 patients with DiGeorge, and they said 4 of them had growth hormone deficiency, they showed quite a good response to growth hormone when treated. So, but yeah, the growth charts are available in that paper that's referenced at the back and is useful, especially as they do seem to have a slightly different pattern of growth to the normal population.
Yeah, thank you. I suppose if there's queries, I would just ask a friendly endocrinologist. Thanks.
Yeah, of course.
Right, thanks, Nadia. That's really good. Thanks for talking on that.